The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. This is Emily Hirio. I'm with the Washington State Department of Health, and I'm pleased to welcome you to this webinar, Myth-Busting Treating Hepatitis C. Dr. John Scott from the University of Washington will be our presenter today, and we look forward to the presentation and hearing the questions that you may have. Next slide. And you can go to the next one, please. So a little bit of housekeeping. If you can, close other windows on your computer. If you're participating via phone, make sure to click OK and mute your computer speakers. Be sure to enter your unique audio PIN if you haven't already. I also want to add that we will have Q&A at the end, but if we run out of time to answer the questions that are put into the chat, we will send an email at a later time with the Q&A to address any questions we don't get to. And you can put into the questions box any questions that you may have. There, I think, also may be a chat feature, but we ask that if you have specific questions to put those in the question box. And then you can see the tabs. There's a grab tab to open and close the control panel, to mute and unmute your audio. I believe you are all unmuted, however, at this point. You can change your audio, computer, or phone. We're not planning to use the hand raising feature, so please do not use that, just use the question pane. You can see the attendee list if you're interested to see who else is on. And then, of course, to put questions in that question pane, and we will get to as many of them as we can today. And if we don't get to your question, we will follow up with all attendees via email. Next slide. Before I jump into this next bit, I also just want to add that the webinar is being recorded and will be available at a later date, both for those who may want to revisit the content and for folks who registered but weren't able to join live today. So I'm going to talk a little bit about a directive from Governor Inslee that came out in September of 2018 to eliminate hepatitis C in Washington State by 2030. And there's two main parts of the directive that I just wanted to make sure people were aware of. So the directive really spoke to numerous state agencies, but specifically looked to Healthcare Authority, who's the host of today's webinar, to develop an innovative procurement strategy to reduce the costs of the hepatitis C medications. As many of you may have heard, some of the initial pricing was quite prohibitive and really difficult for state-funded programs to purchase hepatitis C curative therapies for people living with the virus, and to look at innovative ways to finance public health efforts. And then the other part of the directive was directed at my agency, Department of Health, to bring together stakeholders from diverse sectors to look at a strategy to eliminate the public health threat of hepatitis C in Washington by the year 2030. And I'll just add that this is the work happening in Washington around hepatitis C elimination is really in the context of larger national and international efforts to eliminate hepatitis C. So we are in good company. But this sort of combination of the procurement strategy along with the stakeholder group to develop a plan is really unique to Washington. Next slide. So in order to respond to that second part of the directive around the stakeholder group, we did pull together a collective impact initiative that ended up being called Hep C Free Washington. And our vision is a world free from hepatitis C. And our mission is to work together to eliminate hepatitis C in Washington by the year 2030. Next slide. And we brought together stakeholders from clinical settings, local health jurisdictions, state agencies, people living with hepatitis C, community-based organizations, corrections, substance use treatment programs, a number of folks to come up with the plan, which was released in July of last year. And there's 15 goals and 90 recommendations. And this is all available online, and we can send the link to this, I think, after the webinar as well, if folks are interested in diving deeper into the plan. And just wanted to contextualize Dr. Scott's comments in light of this elimination effort, because treating people for hepatitis C in primary care is really one of the key strategies to eliminating Hep C in the state. Next slide. So now I'm going, sorry for the dog. I was hoping we would avoid it. I'm going to hand it over to Dr. Scott to get into the meat of today's webinar.
Thanks, Emily, and I promise not to bark. My name is John Scott. I'm a professor in infectious diseases here at the University of Washington and the clinic director for the liver clinic at Harborview. Next slide, please. And if you could click again, I just want to show my disclosures. Lita, can you please? I'm sorry. So we're going to talk a little bit about screening, a little bit about the biology, and then we'll get into treatment and then talk about COVID-19. So the first thing I wanted to talk about is just kind of level set is the biology around hepatitis C. So it's a single-stranded RNA virus. You can see on the upper right a model of it. And one of the reasons why it was so effective in eluding the immune system and also why it was hard to grow is when it replicates, it has a very mistake-prone polymerase. It's called the RNA-dependent RNA polymerase. So it makes a lot of mistakes. It creates a lot of different what we call quasi-species, and that has allowed it to elude the immune system in many patients. It's a member of the flaviviruses, so similar to dengue and West Nile virus, yellow fever. There are now 8 genotypes, of which genotype 1 is the most common, and then 2 and 3 are pretty much the rest, at least in our region. So for many, many years, it was hard to grow, but there were some great breakthroughs, and I just wanted to highlight the 2020 recipients of the Nobel Prize in Medicine. And one of them was Harvey Alter, who described the epidemiology of non-A, non-B hepatitis, which became hepatitis C. Dr. Michael Houghton, who discovered Hep C back in the late 80s, and then Charlie Rice, who was one of the first to grow Hep C in culture and did a lot of the basic science and understanding its structure and allowed for the limited advances in antivirals. So next slide, please. So just a word about the epidemiology. For many years, the incidence of hepatitis C was flat, but then starting around 2010, it started taking off, and that was mostly driven by the opioid epidemic. So we see a lot of co-occurring diseases with heroin use and other opioid use. So in 2017, which is the latest year we have from the CDC, there are almost 45,000 new cases of hepatitis C. Next slide. So just a little bit about the natural history of Hep C. If you were to take 100 patients, the good news is that some people do actually fight it off. It's somewhere between 15 to 30%, but the vast majority of people, anywhere between 60 and 85%, will be chronically infected. And then of those people, if you wait 20 years or more, they can get something called fibrosis. And that's really when bad things happen. So we're really trying to intervene and identify people before they develop cirrhosis, because even if you have cirrhosis and get cured, you're at risk for decompensation or end-stage liver disease, around 5 to 6% per year, and also still at risk for liver cancer. And liver cancer is one of the fastest growing cancers in the United States, with a pretty poor survival. But this is a slow process for most of our patients. There are a couple of things that kind of throw fuel on the fire, so to speak, with alcohol probably being the most relevant. So what I tell my patients is that it's additive, and so that 1 + 1 does not equal 2 in terms of the hit to liver. It's more like 1 + 1 = 4. So next slide. So the myth number 1 is here. If you can please click, and I'll read it. So primary care providers should only test patients who use injection drugs, had a blood transfusion or organ transplant before 92, or had a sex partners who use drugs. Next click. And so that is not true. Let me tell you a little bit more about that. Next slide. So I know there are a lot of us were really busy in the spring with COVID, but there are some very key publications that came out in the spring, and this is one of them that was published in JAMA in March, and it was the U.S. Preventative Services Task Force, and they recommended that all adults in the United States between age 18 and 79 get at least a one-time screening test for hepatitis C. So next slide. So the data behind that was displayed here. First of all, is that we're seeing an incredible benefit of being treated and cured with these directly acting antivirals. That's what DAA stand for. And if they get a test 12 weeks after treatment and it's negative, that's called a sustained viral response. For our discussion today, that's pretty much our cure. So those patients who get treated get an SVR12. The all-cause mortality goes down 60%. And then the liver-related mortality goes down even more, 89%. If they have cirrhosis, mortality goes down 64%, and liver cancer goes down 71%. So just gonna put that a little bit in context, quitting smoking reduces your chance of getting lung cancer by about 30 to 40%. So this is pretty powerful. By treating Hep C, you're really making a dramatic impact on your patients' lives. So there also was some modeling done that showed if this strategy was adopted, that over 250,000 HCV-infected patients we identified, leading to curative therapy in 280,000. I think some of these people may even need to be treated more than once, and then avoiding over 4,000 liver cancer cases. So next slide. So next I wanted to talk about some of the blood tests for fibrosis. It's pretty rare in 2020 that we do a liver biopsy, and a lot of these tests are available to you as a primary care provider. So probably the easiest and cheapest one is something called the AST to platelet ratio, or APRI. All you need is a liver panel and a CBC to calculate that. And if you use a cutoff of 1, which is pretty common, the sensitivity is okay. It's anywhere between 60 and 75% with specificity of 64%. And that's going to identify F3 and F4 folks. I am using more and more the Fib4, which is kind of like APRI. It's the same test, but also uses age. And so if it's over 3.25, you get a little bit better sensitivity and specificity. The other test that is available and uses different tests as a part of it is the Fibrosis. So that's a proprietary algorithm. It's often a send out, but it has a pretty good positive predictive value and excellent negative predictive value. So, and I really consider anything over F3 or F4 is advanced fibrosis, and F0 to F2 to be less advanced fibrosis. So if you were going to do this as a primary care provider, I'd recommend you do one of the first 2 tests and a Fibrosis. So next slide. The other non-invasive test that we're using increasingly is something called the FibroScan. And this is something that a lot of the specialty clinics now have. It is a pretty quick and easy test, takes about 5 or 10 minutes. Just as a sound wave in between the ribs on the right side. Next slide. And what it's measuring is the stiffness of the liver. And so the more stiff the liver is kind of a measure of fibrosis. And you get these sound waves that come back. And you get, you'll take 10 readings and take the median of those 10 readings. So for most of you, you may not ever order this, but I'm recommending it if you ever have a discrepancy in the APRI with a Fibrosis. Say one is F3, another one's F1 or F2, it kind of makes a difference in terms of long-term prognosis and what you're going to do with them. So we are scanning those people, and I believe it is increasingly available around the state. Next slide. So we convert this into a scale between 0 and 4, with 4 being the worst, or cirrhosis. And it's just a measurement of the kilopascals, just how quickly the sound wave's coming back. And it's been pretty well validated at this point. It's been around for almost a decade. Next slide. So just a comparison of the FibroScan to liver biopsy. This is from a US cohort using a cutoff of 8.4 kilopascals. The sensitivity is anywhere between 60 and 82%, specificity is at 80% with pretty good positive predictive value. And then you can see the other cut points that we used here. So next slide. So myth number 2, if you can click on the next. So patients should only be considered for antiviral therapy if they have advanced, meaning F3 or F4 fibrosis. So next click, that is not true, and I'll tell you why. So next slide. And this is because the expert guidelines from the American Association of Study of Liver Disease, jointly with the Infectious Disease Society of America, has recommended that the goal of therapy is to reduce all-cause mortality and liver-related health adverse events, including end-stage liver disease. And it is recommended for all patients with chronic infection, except for those who have a short life expectancy, like less than 1 year, and it cannot be remediated with treating the Hep C or transplantation or other kind of therapy. So it's pretty much everyone, and this has been widely adopted. There have been successful lawsuits around the country saying this is now the standard of care. And there also is data backing up that people with early fibrosis have improvement in life expectancy and lower morbidity. So next slide. So next I want to talk about treatment. This is a cartoon from a couple years ago from Mike Lukovich, and it just speaks to the very rapid pace of discovery and development of antivirals. Basically in 25 years, we went from discovery to having almost 100% curative therapy. So I don't know if you can see the scientists are saying it took us 25 years to bring them to these. Let's finish them off. So that's where I'm asking you to help out in helping eliminate hepatitis C. Next slide. So we've made great strides in the treatment of hepatitis C. Some of you may remember the bad old days when we used interferon and ribavirin, which is what we had for the maybe first 10 or 15 years. This was very toxic therapy, had a lot of side effects like depression and cytopenias. And it was, as you can see on this graph, it was not all that effective, less than a 50% chance of cure. The big breakthrough happened in 2013 when we had the first generation of what we call directly acting antivirals. These were really targeted to enzymes that hepatitis C uses to replicate. The first were protease inhibitors like telaprevir and boceprevir. Still needed to use it with interferon ribavirin. And it wasn't until 2016 when we were finally able to drop the interferon and ribavirin. And that was a huge advance. So we were able to go much shorter. It was much less toxic, and then we were getting cure rates in the 90% range. And so the last drugs approved were in 2018 with a drug called glecaprevir, pemventisvir, or imavirit, and then another drug called sofosbuvir, velpatasvir, oxalaprevir, or Vosevi. So I don't think there's going to be any more Hep C antivirals, given how effective and non-toxic they are. That's the good news. We don't have to remember anymore. Next slide. So myth number 3, if you can please click for the text. This is something I hear quite a bit. Active injection drug users should not be treated with antivirals because they have a high rate of reinfection. So that has been busted as a myth. Next slide. There have been a number of studies, and I'm just going to show you the first study that was studying this. It was called the C-EDGE COSTAR study, and this was a study of patients who were in a methadone treatment program. Was done mostly in Australia and Canada, and the patients were randomized to either placebo or this drug called elbowsvir, grosobravir, or Zepatir. It's a 1-pill oral medication for anywhere between 12 and 16 weeks. And these patients had genotype 1, 4, 6, All of them were on some kind of opioid replacement therapy like methadone, and they had been stable on it for 3 months. They did a urine drug screen at each visit. And in the second part of this study, they looked at all those patients who had at least one positive drug test, and it was pretty high. It was 117 out of almost 200, so 60% were in opioid replacement therapy and still using some other medications, with opioids, benzos, and cannabinoids being the most common. And you can see they were a little bit different than the patients who were not enrolled. So the next slide, please. And what you can see is that there was a pretty low reinfection rate. It was 1.8 reinfections for 100 person years. And what you can see is also in the upper left is that the injection drug use was pretty steady throughout the follow-up. So anywhere around 20 to 25% after enrollment. And there was also some non-injection drug use, more in the 40% range. But there were 5 reinfections as part of the first part of the study, and then 1 during the follow-up period, and then 4 in the second part of the study. So pretty low reinfection rate. Some interesting things happened with those people who got reinfected. 2 of them went on to clear on their own. So they got reinfected and then they just cleared it on their own. And then 5 of them got treated again and were cured and not reinfected. So this is pretty low, and is pretty much in line with other studies like the Anchor study of different agents. The highest I've ever seen is about 5 reinfections per 100 person years. So it's pretty darn low. So next slide. And so just before we get into the specifics, we do treat active injection drug users. It is part of the guidelines, and I personally have done it, over a dozen times. And actually, it will often start a virtuous cycle. I've seen some people start the antivirals and they then want to get on Suboxone or methadone, and they are able to stop using drugs. So it's kind of rewarding to see that that change as well. So I'm going to talk about some of the first-line therapies that are available. The first drug that was approved is a drug called sofosbuvir, ledipasvir, or Harvoni. I mentioned to you the glecaprevir, pembrolizumab, which is also known as Mavorite, and then the other one we were just talking about, elbasvir, grazoprevir, and finally sofosbuvir and valpanosvir, Epclusa. A little bit of differences. You can see that Harvoni and Zepatir don't get all the genotype. It's only the GP and Sofvel that get all the genotypes. But across the board, pretty good efficacy. So SVR12 rates over 95%. And almost all of them have kind of the same side effect profile, with it there being 3 broad categories of side effects. The first being fatigue, the second being a little bit of nausea and vomiting, and then the third being headaches. And those are all pretty mild. I'd say about 20% max will get at least one of those. You can also see that when they first came out, they're not cheap. So Harvoni made the press because it was the $1,000 a day pill. And then glecaprevir, pembrolizumab made news because it came out at a very lower, much lower rate. And these are all wholesale costs. I'm familiar with some of the commercial plans, and they are negotiating this for a much lower rate. So this very rarely was actually paid. A couple of comments about each of these regimens. I use all of them, and I'll just say that some of them are nice because they are 1 pill a day, like the Harvoni and the Epclusa. The GP is nice because there's an 8-week option, and it's good for patients who have advanced renal failure or have this mutation called the Y93 mutation. But you should know that almost all these are really good options. So next slide. So we mentioned a little bit about the sustained viral response, And there are now really good data showing that it correlates with meaningful outcomes. The first being that the liver histology improves. That means if we do a biopsy before they start treatment, and then after they get cured, that we see a lot of decrease in inflammation, about 87%, and almost half of them will have less fibrosis versus those who are treated in relapse. Also, survival improves. I mentioned some of the studies earlier, about 60 to 70% reduction. There are some versions of splenic lymphomas in particular that are activated by hepatitis C, and if you treat the Hep C, you can actually make the splenic lymphoma go away completely, so you don't ever have to get chemo. So that's kind of nice. And then probably more relevant is that because the liver is such a metabolically active organ, if you treat the Hep C and you have a patient who's pre-diabetic, you can reduce their chance of getting full-blown diabetes by up to 50%. So lots of benefits for the liver and outside of the liver. Next slide, please. So myth number 4, in Washington State, only specialists are allowed to prescribe directly acting antivirals for chronic hepatitis C. This was true in the past, but is no longer true. So I'm gonna go to the next slide. And there's a great map, if you're interested, of all 50 states and their policies. This was compiled by the Harvard Law School and the National Viral Hepatitis Roundtable. And the website that is there, stateofhepc.org. I'm really happy to say that we got an A here in Washington State, and that speaks to the lack of any provider restrictions or sobriety. So this has been, really been a great advantage for getting our patients access to Hep C medications. Next slide, please. So next I want to talk about some ACV care models. So I have another role at UW Medicine, that's that I direct the telemedicine program. So I wanted to tell you about a study that used telemedicine for treating Hep C. This is particularly relevant in this time of COVID and patients not wanting to come in. So this study was published in Clinical Infectious Diseases last year, and Dr. Talal and his colleagues performed this in upstate New York. The way it worked is he partnered with a methadone clinic in New York, and they had some baseline labs for the patient. They confirmed that the patient had infection with an RNA test. Then Dr. Talal and his colleagues saw the patient by telemedicine, told them about the treatment, and once they decided this patient was a good candidate, they wrote the prescription and they coordinated the dispensing of the ACV medications with the methadone clinic, so kind of a one-stop shopping for the patients. And they were able to evaluate, I think they had 100 patients initially, but got down to 62 patients, of which a lot of them had HIV, 24%. Also a lot of advanced fibrosis, 34%, and a large minority population, 60% were African American. They were able to get 45 of those patients treated, and 93% of them got a cure. I would just note that there were 10 patients who they had written a prescription but did not start therapy because of insurance issues. So pretty good model, you know, working with methadone treatment facilities and using telemedicine. So next slide. Later, if you wouldn't mind clicking it about 4 or 5 times, thanks. So next I want to talk about Project Echo. So this is a program that is supported by the Washington State Department of Health, and I started in 2008. And it's kind of like a case conference model. We do this every Tuesday at noon, and we start off with a didactic. It's a 15-minute didactic on hopefully really relevant information. We don't get too much into the weeds. And then we hear from cases around the Pacific Northwest, with most of them being Washington State. Almost all these people are primary care physicians. We have a couple pharmacists, ARMPs, a couple medical students and residents in there. And they present to not just me, but my colleagues. I have a board certified transplant hepatologist, a nurse practitioner who specializes in liver disease, an addiction medicine specialist, and mental health specialist. So you get 4 brains for the price of 1, and also a lot of great problem solving from your colleagues around the Pacific Northwest, and it really is fun to learn from your colleagues. We call these learning loops. So next slide. So the reason why ECHO works is it is supported by 4 pillars. The first is we're using technology. In this case, we're using Zoom to leverage scarce health resources so the patients don't need to travel, and that expertise is being built into the community. It's also case-based learning, which is from our colleagues in academia. We know that's how adults learn best, is really to hang principles and concepts on actual patients. And we're using best practices in that case-based learning. We're using a disease management model. So really, kind of similar protocol on these cases, and we do monitor and evaluate the outcomes for QI. Next slide. So one of the cool things about ECHO is it increases capacity. We're building kind of mini experts. So rather than referring to the referral centers or liver clinics like here at Harborview, we're trying to get more of the community to be experts in taking care of the patients in their local community. So next slide. So you're probably wondering, is this safe and effective? And it turns out there was a landmark study in the era of interferon ribavirin that showed it is indeed safe and effective. And it was done at the University of New Mexico, where patients were either treated through ECHO, these were rural and underserved clinics, or they were treated at the Academic Medical Center in Albuquerque. And the cure rates were almost exactly the same. The interesting thing was the adverse event rate was actually lower in the ECHO sites, and they also treated more minorities in the ECHO group. And this has now been repeated in the DAA era, multiple other publications showing the safety and efficacy of ECHO. If you're interested, please contact me. We have space to hear your cases. As I said, it's every Tuesday at noon. We go till about 1:30. So next slide. So finally, I just wanted to end with some challenges with COVID-19. Next slide. And I think one of the first things that we've noticed at the liver clinic and at UW are there were fewer ambulatory visits for chronic diseases starting in the spring, and kind of we're picking back up in the fall, but now with the resurgence of COVID cases, kind of seeing more people with staying home and deferring some of that follow-up care. And we've really seen fewer referrals and treatment initiations this year. We know that this is a competing priority for many clinicians and patients, and also that a lot of our patients have lost their health insurance and are worried about the cost of treatment. So next slide. So the other thing I wanted to talk about is the effect of COVID-19 on the liver. So this is data that is mostly from China. And the good news is that COVID-19 is not as tough on the liver as it is on other organs, but up to about 25% of patients in the largest study with Guan had some kind of transient elevation in their AST and LT. It usually took a couple of weeks to get back down, and it didn't seem like it went into any kind of fulminant liver failure. The times where there were really bad liver disease was when there was widespread ARDS, heart failure, and it was probably just the whole body just being attacked by COVID-19. So next slide. I want to talk a little bit about the American experience, and this is local. This is the JAMA paper from Evergreen Hospital. So it's describing the first 21 patients there in their ICU with a mean age of 70. The mean time from onset to hospitalization was about 3.5 days. And not surprisingly, almost all of them had some kind of abnormal chest x-ray with a kind of a reticular lacy pattern being the most common. 33% had a cardiomyopathy, and 38% had abnormal LFTs. And you can kind of see over here on the lower right, the bilirubin, unfortunately, was not very very high. AST mean was 273, ALT is 108. And my understanding is that those who survived, that their LFTs did normalize. So next slide. So that's all I have for you today. Hopefully we'll have some time for questions. And if not, I think Emily has some other information to share. Emily.
Yeah, right now there's one question in the chat, which I will ask, but just to remind folks, if you do have questions, please put them in the question box. So the question we do have, Dr. Scott, is around reinfection. So when measuring the low reinfection rate post-treatment, is that attributable to how effective the antivirals are versus getting reinfected by injection drug use with Hep C virus, or something else?
Yeah, I think what people are asking is, does the treatment somehow protect them from reinfection? And I think there's some very intriguing evidence that it does, that somehow it boosts their immunity. So that's one thing. I think also I've seen this multiple times, that I think it's often a time for patients to get serious about, trying to quit drugs altogether, or being introduced to safer injection practices. So it's surprisingly low, and I think that we're going to cure a lot more people than we think we could.
Great. A second question has come in. Could you go over starting the treatment regimen and monitoring, and how you select your medication?
Yeah, maybe I'll take that first. The question about how I choose the medications. Quite honestly, I look at a lot of this is driven by their insurance. So if they're a Medicaid patient, GP or Mavorite is the preferred regimen. And then it just kind of depends on the insurance of what other regimens out there. Typically, I'm looking for a pan-genotypic regimen, so get any kind of genotype. You don't necessarily need to get a genotype anymore. About the only time I would get a genotype is if it's a cirrhotic patient. And I found out that they were genotype 3. Those people are a little bit harder to cure, and I just want to keep a little bit closer eye on them. But I'm not getting the genotype on everyone. And in terms of monitoring, if they're F0 to F2 and they don't have Hep B, I actually just kind of see how they're doing with side effects. The new ASLD guidelines do not recommend doing on-treatment monitoring. So remember, we used to do like 4-week viral load, we used to get LFTs. They just haven't been shown to be at all valuable, and just add the cost. So we're really reducing the amount of lab cost and inconvenience that a lot of our patients need. And if you joined ECHO, we could go through individual cases and kind of guide you on when we do get labs.
Great. There's a follow-up to that around insurance. Is there a single resource for what insurance covers, or do you have to check them each as they come in?
Oh boy, I'm really fortunate that I have amazing pharmacists at our liver clinic. They kind of keep that list going. I think in general, the insurance companies will either cover Mavorite or Epclusa. So you can kind of get comfortable with one of those two, or if you're going to be treating enough, you probably should know both. But that's kind of been my experience. About 90 to 95% insurance companies are opting for one of those regimens. And I'm not sure if we have anything here in Washington State where like one-stop shopping. Emily, are you aware of anything like that?
I've seen that in for the marketplace plans in other states, where advocates have created a guide for Hep B and C treatment for the marketplace plans. But of course, that's a small percentage of the insured population. I can look, and if we find something, we can send it out with the recorded webinar information. We have a number of other questions. So someone's asking, did I hear you say that you always do a FibroSure on everyone, or are there lower risk patients who can just use Fib4 or APRI?
Well, so I'm a little bit different in that I have a FibroScan, and I really think that's the best non-invasive test. So just kind of take that with a grain of salt. I do use a FIB4 or an APRI, and I've been using the FibroScan as my other non-invasive test. I would recommend you have at least 2 non-invasive tests that are looking at different technologies or different tests. So if you don't have access to FibroScan, then yes, do a FibroSure. And if the results are concordant, like they both say F4 or they both say F0, F1, then you're good and you can kind of proceed. The tricky thing is when one says F3, F4, the other one says F0 to 2. And the reason for that is the patients who are F3, F4, even if they get cured, they do have a long-term risk for liver cancer, and you need to screen those people indefinitely for liver cancer. So I just, in general, the FibroSure has been the least accurate of all those non-invasive tests. I've kind of just seen some wacky results. So that's why I personally am kind of steering away from it and using my FibroScan more.
Thanks. So this is a question around co-infection with HIV. What do you recommend when treating co-infected patients that are treatment naive? Which virus do you treat first?
Yeah, that's a great question. So first of all, for a long time, HIV co-infected patients did not do as well with Hep C therapy, and that's no longer true. They have the same really high cure rates. And I kind of prioritize the HIV just because I think that's the more serious of the infections. And there's also transmission risk. So I typically would get that under control. And as maybe you know, the integrase inhibitors are kind of the most recommended HIV medication with a backbone like Truvada or TAF plus FTC. And those work very well with any of the Hep C medications. So the integrase inhibitors in particular have very few interactions. The Harvoni, there was a little bit of an interaction with Viriad or TDF, and you just needed to watch their renal function a little bit more closely. But in general, they're gonna play very nicely together. If you're ever concerned about a drug-drug interaction with your Hep C medicines, there's a great website, and if you just Google HCV Liverpool, it's from the University of Liverpool, and they've created this database for all the Hep C medications, and then pretty much any other medication, and you can very quickly see if there's a bad drug-drug interaction. So I use that pretty liberally, and my pharmacists do as well.
And just on that topic, in Washington, we have about 10% of people living with HIV are co-infected with hepatitis C, which is actually a bit lower than some other states. Some have up to 25%, but it's definitely an issue. And we also see some Hep C infection through certain types of sex, particularly among gay men who are living with HIV, gay and bisexual men. So a good thing to kind of keep an eye out for. This is about pregnant women with hepatitis C. When is the best time to treat them? After delivery, after breastfeeding? Are sort of the questions there, how to manage Hep C in pregnant women.
Yeah, so first of all, if you look at the CDC guidelines, they do recommend screening pregnant women for Hep C. So again, people may not know that. There's only been one clinical trial of a DAA in pregnant women. I think it was with Harvoni. It's from the University of Pittsburgh group, and they treated 10 women who were pregnant, and they all did really well. They all got cured. There were no birth effects in the babies, but it's not FDA approved, so not a whole lot of data. So I personally, I let them get through their pregnancy and just make sure they're at a good place socially, and they're not super tired and stressed out from having their baby, and then we'll just talk to them about when's a good time to treat them. I do it after they've weaned their baby, because we don't have a whole lot of information on how much of the antiviral was passed through breast milk. So pretty much wait for them to get through the childbearing and early childbearing. Oh, another thing I wanted to make sure everyone knew is that the glycopropiovir remdesivir does interact with certain kinds of hormonal contraceptions, especially the estrogen containing, and it lowers its efficacy. So if you have a woman who's on birth control, you want to switch to more of a progesterone containing or an IUD or something else, but otherwise they might get pregnant.
Those are the questions we have thus far. If there are any additional questions, please put them in the question box. And if it looks like we have time, I could go through those last few, some state data, if that would be of interest to folks. I can do it quite quickly. But I think somewhat relevant to this question about pregnant women, because we're seeing some increases among younger people. So just very quickly, we worked with a modeling group called the Center for Disease Analysis Foundation, and they did some modeling for the calendar year 2018, estimating prevalence of viremic hepatitis C in the state, the estimate of the people diagnosed and then treated and cured during 2018. So you can see, we have an estimate of about 59,000 people living with hepatitis C. Of course, there's a range there, but that's sort of the middle of that estimate. And you can really see we seem to be doing well by the modelers' predictions in terms of diagnosing people at about 88% of people living with Hep C knowing their status. But where our kind of cure cascade or continuum of cure falls down is that piece between diagnosis and treatment and cure. And that's a big part of the work you all can really help us with, is making sure that blue bar and the green bar are more equivalent in height. Next slide. And then just some quick data looking at chronic hepatitis C and acute hepatitis C. We've had rates of chronic hepatitis C rise in the last few years. We think for 2018, there were about 8,000 chronic infections reported. That, of course, does not mean the number of people actually acquiring Hep C in 2018, but those reported to local public health departments. And we had our highest rate of acute infections in 2018 since I think about 1995, which was 118 reports of acute infection. And we know those acute infections are really just the tip of the iceberg. So we're definitely seeing more incidents. That could be both a combination of better screening for acute infection, better, clinicians being better at kind of identifying it. And I think it also is a bit of real increase in incidents. Next slide. And then just real quickly, we have some more questions, so I want to see if we can get those answered. But wanted to just show we're seeing a real age shift among our chronic cases. The blue graph is 2007, the orange is 2017. And you can really see in the gray shaded area, those are the baby boomers, the people CDC was talking about for a while as being most affected by hepatitis C and who we really needed to identify, diagnose, and treat. And you can see we had sort of a one-humped camel in 2007, and by 2017, really starting to see a two-humped camel with much younger people rising in terms of prevalence of chronic hepatitis C. And as Dr. Scott mentioned, sort of nationally, that's been attributed to increasing opioid injection. I think in the West, we also see quite a bit of methamphetamine injection that has increased over the last few years. So certainly sharing of injection equipment, inadequate access to sterile equipment are contributing to chronic hepatitis C among this younger group. And the next slide. And then just the last thing I wanted to show, this is just 2017 and 2018. And you can see that rise in younger people becoming more pronounced even just between those 2 years. So this sort of universal screening and treating and curing people in primary care is a really critical part of tackling this issue. I think that's all I had. Did I have another slide? I don't think I did. No. Okay. So we've got about 8 minutes. I just wanted to provide that sort of more local context in light of the national numbers, since we had some time. But some additional questions. If someone refuses a biopsy, can they still receive treatment?
Yes, definitely. In fact, I can't remember the last time I did a biopsy. It was probably 3 years ago. These non-invasive fibrosis tests are really considered to be the most frequently used assessment for fibrosis, and they're not as good as a biopsy, but they're still pretty darn good.
Yep. And then the last question I have right now is anyone doing child PU scores?
I do for my cirrhotic patients, and this is a great point, that you do not want to use any regimen that has a protease inhibitor in a child's B or C patient. So that would be like Mavorite, Vosevi, or Zepitir. They all have a protease inhibitor, and we saw about 5 or 10% in the clinical trials with those agents that they had child's B or C, that it actually made the liver worse. So pretty much your only regimens in a child's B or C are going to be Epclusa or Harvoni. And the way you calculate the child's B is with some labs and plus the presence of ascites and encephalopathy.
All right, that was the last question we have. We have 6 more minutes. So, looks like there is a comment from our colleagues at AbbVie, just asking if we could clarify that Mavorite is exclusive for all Medicaid patients with no prior authorization. Yes, so in the Medicaid program in Washington, if a patient is appropriate for Mavorite, there's no prior authorization for that medication.
Yeah, it's taking about a week or two to get all the paperwork through. So things are happening pretty quickly.
All right, any other questions?
So it might be good to know about other resources that you can take advantage of. I quoted pretty liberally from the ASLD guidelines. If you just type in HCV guidelines in Google, it'll come up. The other great resource at the University of Washington is something called HCV Online. It has a curriculum kind of walking you through epidemiology and staging, and it has all the medications. If you want to see the actual studies, there are, I think, over 1,000 slides on all these studies, and you can download them if you need to give a talk or whatever. But that's a great resource as well.
And I would add that that has CMEs, right, and nursing credits as well. So
Sure.
if folks are looking for that, that's available through that website. So 2 more questions have come in. Is there a minimum, they're related, so I'm gonna ask you them both. Is there a minimum time frame after infection is diagnosed that you would recommend waiting to treat? Specifically asking about acute hepatitis C, do you wait to see if they clear the virus on their own or just treat?
Yeah, that's a great question. So remember that one natural history slide where 15 to 30% of people clear on their own? I usually give them up to 3 months. If I knew exactly when their last exposure is, say like someone got a needle stick, and you knew exactly when that day is, I'd give them 3 months to kind of declare themselves. And then after that, I'd treat them. Often we don't really know if they're acute or not, because there's, maybe they're active injection drug users, and we don't have any prior tests. And in those cases, unless there's like a really high flare in their ALT or ST, I just go ahead and treat them, because you want to take advantage of having them there and motivated for treatment. So sometimes it's really hard to know whether it's acute or chronic.
And I would just add that for those of you that see patients who have Medicaid, there is no requirement to wait for evidence of chronic infection. So if you have a situation where it's unclear if they have an acute or a chronic infection, you can go ahead and order prescribe the medication. You don't need to wait. to, 6 months or anything like that. I'm not sure that's true with other kind of health coverage, but certainly with Medicaid, you don't have to have proof of chronic infection. All right, we've got 3 minutes. I know Dr. Scott has a hard stop at 3, so just seeing if there's maybe 1 or 2 more questions, and then we can wrap up. All right, well, I'm not seeing anything at the moment. Dr. Scott, is there anything you would like to say to wrap up?
Yeah, I would just say that treating Hep C is really fun. I worked in primary care before specializing, and I know that a lot of what you're doing is chronic disease management, and it's really hard to cure a lot of things. This is something that is pretty easy to cure, and you can save their life. So I would encourage you to jump in, and there's lots of support available here in Washington State.
Great, thank you so much for your remarks and presenting the slides. And I'll just piggyback on what you said. I think this is a super exciting time from a public health perspective with hepatitis C, because this is something we really can eliminate. And Washington has all of the tools to eliminate hepatitis C. We just really need to scale them up. So, fairly easy access to curative therapy. We have, good access to medications for opioid use disorder, harm reduction services and syringe access, and a lot of really fabulous primary care providers, and Medicaid expansion, which is so critical. So I think, we're here to recruit you, and we appreciate your time. And I hope everyone has a very excellent weekend, and we will send out the recording of the webinar. I think we got to all the questions, so we won't be following up with any of the Q&A. And maybe some of these links that Dr. Scott mentioned, because they're really fantastic resources. Thank you all for being with us today. Bye.